Good morning, good afternoon, good evening, everybody. My name is Mark Toy, the Tokyo Metropolitan Cancer Center Hospital. I would like to start the special lecture by Professor Kinoshita, particularly on the very interesting title, the non-surgical ablation for primary breast cancer. And just briefly, I'd like to introduce the background with Dr. Kinoshita. He graduated the Keio University and they spent multiple years in Keio University Hospital. And then he moved to the United States, University of Tennessee for 2 years, and then back to the Tokyo. And they spent many years in National Cancer Center Hospital. And he has led the breast cancer research and also practice in that institution. And also he has led the breast surgery field in Japan, in Asia. And he appointed two executive director, the member of the executive director of the Japan, the Breast Cancer Society. And then he appointed to the current position, the vice director of the National Tokyo Medical Center. And if you have any question, you can post them at the Q&A box, and he will try to answer them at all the end. Okay, is it ready? Professor Kinoshita, please start your lecture.
Yes. So thank you for giving me the chance at the STARMED RFA webinar. I appreciate the webinar chair Professor Masakazu Toya and participant EU. I'm going to talk about US-guided radiofrequency ablation therapy, non-surgical ablation method for the treatment of early breast cancer conducted in Japan. これがある。すみません。なんか、これ消しちゃって大丈夫かな。これが邪魔なんだけど。Wait a moment. これでいいか。あ、thank you. So background of this study. Currently, the rate of early breast cancer continues to increase in Japan because increasing breast cancer screening rate, progress in diagnostic imaging, increased precision of mammograms, ultrasonography, magnetic resonance imaging in second and subsequent screenings. Simplification of definitive diagnostic method, progress in needle biopsy methods for detecting calcification and microlesions. So, however, what about local treatment method? Progress is being made with minimally invasive technique, for example, breast conserving surgery and sentinel lymph node biopsy. Nevertheless, resection remains the first-line therapy. So we wondered whether we could establish a therapy without resection according to modern needs and patient preference. Therefore, we started to conduct research on such a therapy. These are the types of devices for non-surgical ablation therapy that are currently available in Japan. Three types of device. One for cryoablation, another for MR-guided focused ultrasound surgery, and the other for radiofrequency ablation are investigated for the use for breast cancer. I will explain the principle of radiofrequency therapy. In this therapy, Joule heat is generated by applying the electric current for medical use for a frequency close to that AM radio wave to the tissue. The higher the level of resistance is, the more Joule heat the electric current generates. In radiofrequency therapy, tumor necrosis is caused by using this heat. We understand that in the liver model, using a radiofrequency system single needle, the area shown in the figure can be ablated. This is area measures 0.5 centimeter from front to back and 1.5 centimeter in width. The effect of ablation and the area ablated in the breast tissue were not known before these studies, as these tissues have different resistance for the liver. Temperatures above 50 degrees have irreversible effect on tissues, and tissue carbonization and vaporization occur at 120 degrees. The aim of RFA treatment is thermal coagulation of patient, and the target final tissue temperature is therefore at least 60 degrees. First of all, this slide shows RFA procedure for early breast cancer. The electrode is placed through a small incision under the ultrasonography guidance. Thermal ablation is performed until the power roll-off, which occurs with the tissue coagulation. The skin is protected by placing an ice pack during the procedure. The electrode is removed and the bandage is just applied. The following slide shows the standard RFA procedure that has been established by our study group. Now I'm showing you a video, an actual RFA procedure for breast cancer that was performed under general anesthesia. In this patient, ultrasonography showed a localized mass on the lower outer quadrant of the left breast. The maximum diameter was 4 millimeters. MRI revealed the same findings. The diagnosis based on needle biopsy was invasive ductal carcinoma. First, the tumor is visualized with ultrasonography and an RFA needle is inserted into the center of the tumor. So tumor is visualized by intraoperative ultrasonography. Puncture site is determined to allow for accurate insertion of the needle into the center of the tumor. A small incision is made at the puncture site. Surgeon inserts the RFA needle into the center of the tumor under ultrasonographic guidance. Check if the needle tip is protruding by approximately 5 millimeters and make sure that the skin around the puncture site is outside of the ablation area. Tissue impedance is measured. High impedance might lead to insufficient ablation. Therefore, if impedance is high, appropriate measures need to be taken, such as changing the puncture site or the position of the return electrode. Usually, the appropriate impedance is 250 ohm or lower. Before ablation, a procedure for burn injury prevention is performed. The glucose injection needle should be inserted under ultrasonographic guidance in a direction that avoids contact between the injection needle and the RFA needle. 5% glucose should be injected between the tumor and the pectoral muscle first, and then between the tumor and the skin to allow for a sufficient distance from the ablation area in order to prevent burn injury. A total of approximately 30 ml of glucose is injected. After 5% glucose is injected, impedance is measured again. Then ablation is started. Start to apply radiofrequency energy at 5 watts. During ablation, the skin immediately above the ablation site is kept cool with an ice bag to prevent skin burn injury. Next, the radiofrequency energy is increased to 10 watts. Therefore, the output is increased in increments of 10 watts at 1 minute intervals. After the final step, the surgeon checks the thermal parameters after ablation. After a break, measures the temperature of the tumor at the RFA needle tip. Checks the ultrasonographic image. After a break occurs, the temperature of the tumor is measured with a thermal sensor integrated into the RFA needle tip. Next, RFA needle is withdrawn 1 centimeter to measure the temperature near the center of the tumor in order to make sure that the target temperature has been achieved. No bleeding occurs because the tissue is well coagulated. In this patient, the temperature after the RFA needle tip was 92 degrees, and the temperature at the center of the tumor, which was measured by withdrawing the needle 1 centimeter, was also 92 degrees. Therefore, target ablation temperature was achieved. So means the tumor was successfully ablated. Ultrasonographic images before and after ablation are shown. They show bubble-like change in the heat-coagulated site. The surgeon measures the area with these changes as the ablation area. Usually, an area of approximately 3 centimeters in diameter is ablated when a 2 centimeter needle is used. So this is the roadmap for obtaining regulatory approval for RFA for early breast cancer in Japan. Our studies consist of 3 studies. I'm going to talk about each study briefly. The purpose of study 1 was to confirm the clinical usefulness and safety of RFA for EBC. RFA was performed under general anesthesia. Following the procedure, incidence and level of adverse events were recorded. Immediately after the procedure, partial resection of the breast was performed as planned. Specimen of resected tissue was histopathologically examined, and the tumor necrotic effect was evaluated. So summary of clinical study 1. In 33 out of 50 patients with tumor of diameter 3 centimeters or smaller in ultrasound imaging, H&E and NADP DPH staining of the specimen of rejected tissue confirmed that efficacy of RFA was 100%. In 89% of patients with tumor of 2 cm or smaller diameter, or 89% of EIC negative patients, complete efficacy of RFA was obtained. As complications in this study, skin burn in greater pectoral mass were observed in 2 and 3 patients, respectively, but these complications did not pose any problem during the clinical course. So I'm going to talk about clinical study 2. This slide presents the treatment in the protocol. This was our first prospective study of RFA without resection. After diagnostic imaging, including MRI, needle biopsy was carried out and eligibility for participation was confirmed. Then, after patient-informed consent was obtained, RFA was carried out under general anesthesia. After RFA, standard breast irradiation and adjuvant drug therapy were carried out. Breast imaging was scheduled at 3, 6, and 12 months after RFA. The VAB, vacuum-assisted biopsy, was scheduled at 3 and 12 months after RFA. When incomplete ablation is suspected, either or imaging or biopsy specimen, surgical resection must be performed for the confirmation. These are the endpoints. This slide shows the study profile. 57 patients underwent RFA. 1 patient denied follow-up. A total of 56 patients, including 49 without resection and 7 who underwent resection, were alive without distant recurrence during the median observation period of 85 months. 1 patient was diagnosed with ipsilateral breast tumor relapse and 1 with contralateral breast cancer during the subsequent follow-up. So the screening, 55 performed screening at 3 months after RFA. 8 patients suspicious of incomplete ablation and resected tumors, and 2 residual IDC, 3 residual DCIS, and 2 no residual tumors. So screening at 12 months, 46 patients had no residual tumors. So these are the outcome of RFA for early breast cancer with a median follow-up period at 85 months. So in this study, the VAB system played an important role to monitor the disease after RFA. Because high precision examination of tissue is required for judgment to determine the completion of the treatment specified in the protocol. Residual lesions are evaluated by VAB rather than CNV. In addition, tumor viability in the biopsy samples is evaluated by H&E staining and either NADH or single-strand DNA staining. In our hospital, VAB is mainly used. Approximately 13 samples are collected continuously from the central and the marginal regions, which are sufficient for evaluation for incomplete ablation.
少し押されたり握ったりというところになりますからね。
Of the post-RFA VAB. With the ultrasonographic imaging, That is isoechoic mass. This is the ablation zone.
じゃあうるさい音今から鳴ってきますよ。驚かないでくださいね。
Samples are collected continuously in central and marginal regions. Aura.
少し押されたりに
This is a typical histologic image 3 months after RFA. Tissue in tumor central regions shows coagulative necrosis. The NADPH staining judged these cells are non-viable. The feature of coagulating necrosis is chromatin condensation, acidophilic degeneration, decreased staining. This slide shows the change in the breast MRI findings, which time after RFA. At 3 months after RFA, the ablated sites show vacuolation and the margins show contrast enhancement. However, the ablated sites are subsequently assimilated and decrease in size, and contrast enhancement at the margins can no longer be seen. This slide shows the change in breast ultrasound findings with time after RFA. The central part of the ablated area is hypoechoic and the margins are isoechoic. With time, the hypoechoic region is gradually replaced with an isoechoic region, and the whole of the ablated area also gradually contracts and is assimilated. This slide shows the US and MRI findings 4 years after RFA. No induration was found by palpitation, and the breasts were not scarred and mishappened, so that outcome was satisfactory in aesthetic terms. So during follow-up period of 7 years, it is nevertheless expected that RFA will have a good aesthetic outcome and will not be inferior to partial breast reduction with respect to local controllability. In the histological diagnosis 3 months after RFA, incomplete ablation was detected in 5 patients, 9.1% of the total. However, in all cases, the findings were microlesions that could not be detected by diagnostic imaging. So the study 3 commenced in August 2013. The study was completed 2 years ago. We named this study RAFAEL study. I'm going to present final data of this study. This slide shows patient inclusion and exclusion criteria of the study. So females between 20 and 79 years of age with a single localized tumor of 1.5 centimeter or less in the greatest dimension on preoperative imaging, including enhanced MRI. No prior treatment for breast cancer. And exclusion criteria. So extensive cases with extensive calcifications on mammography. Synchronous breast, bilateral breast cancer. So suspicious of extensive lesions in breast ducts or multiple lesions based on imaging. So this is the schema of the protocol treatment of the study. After diagnostic imaging and biopsy, RFA will be performed under general anesthesia. 3 months after adjuvant radiotherapy, we perform VAB of the ablated tumor to confirm the complete ablation. If the residual cancer is detected, surgical lumpectomy must be performed. After that, we schedule clinical breast examination every 6 months for 5 years. The slide shows the study design. The planned sample size was set at 372, considering patients lost to follow-up to achieve the power of 80% with a one-sided alpha of 5%. The expected 5-year IBTR-free survival, ipsilateral breast tumor recurrence-free survival of 93.7%, and the threshold of 90%. These are the endpoints of the study. Primary endpoint, 5-year ipsilateral breast tumor recurrence-free survival. Secondary endpoint, incomplete ablation rate, overall survival time, duration of distant recurrence-free survival, adverse events. So between August 2013 and November 2017, 370 patients were enrolled from 9 institutes. The interim analysis specified in the protocol was carried out on January 8, 2016. Number of patients enrolled achieved the target number at November 29, 2017, and then enrollment of patients was stopped. So no severe adverse events were reported during this time. This is a patient baseline characteristic of the study. So mean age was 55.8. The range was 32 to 78. The tumor size by US was mean was 9.8 millimeter. Tumor size by MRI mean was 10.7 millimeter. Most of the patients were invasive ductal carcinoma, and the receptor status, so ER positivity was 95.8%, and HER2 negative was 90.4%. So sentinel lymph node biopsy was performed 352 patients, and node negative patient was 92.1 patient. So RAFAELO study was planned and conducted to demonstrate the non-inferiority of RFA compared with partial mastectomy as a local therapy for early breast cancer. The study enrolled 372 patients, of whom 370 patients received RFA per protocol. Of the 353 underwent the following screening and were included in the analysis. An imaging study and needle biopsy 3 months after radiotherapy, and an imaging study 5 years after radiotherapy. Based on the result of the vacuum-assisted biopsy after RFA, 15 patients were suspected to have incomplete ablation and underwent lumpectomy. Residual lesions were detected around the ablated areas in 6 patients with ductal carcinoma in situ and 4 patients with invasive ductal carcinoma. The incomplete ablation rate was 2.8%. 10 out of 353. The primary endpoint of the study is 5-year ipsilateral breast tumor-free survival. 4 cases of relapse have been reported. 2 patients developed relapse in the lung and the distant node and in the liver, respectively. 2 patients developed relapse in the ipsilateral breast 880 and 1548 days after RFA. However, 2 patients developed relapse in the contralateral breast 352 and 1790 days after RFA. 2 patients experienced a relapse in the ipsilateral breast within 5 years. The 5-year IBTR rate was 0.57%. Relapse in these patients occurred 880 and 1548 days after RFA, respectively. Both patients experienced the relapse in areas distant from the primary tumor and more than 2 years after RFA. Therefore, the relapse tumor was considered new primary tumors, rather than tumors arising from the incomplete RFA. 2 patients died from different disease and another 2 died from the primary disease. 349 patients were surviving. 2 cases of relapse in the distant organs and 4 cases of death have been reported. 2 patients developed relapse in the lung and distant node and in the liver, respectively. Throughout the RAFAEL study, CTCA grade 3 or higher adverse event occurred in 4 patients, 1.1%. No unexpected adverse event occurred. Regarding grade 3 adverse event after the end of the protocol treatment, wound infection occurred in 3 patients, and skin necrosis occurred in 1 patient. Mammography finding in the pre-RFA image, the tumor was too small to be detected. Even after ablation, the tumoral shadow could not be detected, and the translucent image consistent with the ablated part was seen. Over time, the size diminished. Dystrophic calcification may sometimes occur. These pictures show the changes in breast ultrasound findings with time after RFA during 5 years. The part of the ablated area is hypoechoic and most of the area is isoechoic. With time, the hypoechoic region is gradually replaced with the isoechoic region, and the whole of the ablated area also gradually contracts and is assimilated. These pictures show the changes in breast MRI findings with time after RFA over 5 years. At 3 months after RFA, the ablated sites show vacuolation and the margins show contrast enhancement in some cases. However, the ablated sites are subsequently assimilated and decreased in size, and contrast enhancement as the margins can no longer be seen. So summary, the RAFAEL study was planned and conducted to demonstrate the non-inferiority of RFA compared with partial mastectomy as a local therapy for early breast cancer. During 5-year follow-up period of RAFAEL study, 2 patients, 0.57%, experienced a relapse in the ipsilateral breast. 2 experienced relapsed at distant sites. 2 died from breast cancer and 2 died from other diseases. The 5-year IBTR-free survival was 98.6%, and the primary endpoint was met as a lower limit of 90% CI exceeds the threshold. Throughout the RAFAEL study, CTCA grade 3 or higher adverse events were reported in 4 patients. No unexpected adverse event occurred. So these are the conclusions. The RAFAEL study demonstrates that RFA is a promising alternative to surgical excision for small early breast cancers, especially luminal A subtype, in appropriately selected patient populations. Patients with breast cancer in Japan can now avail themselves of this treatment that are subsidized by public insurance.
Some good news for people with.
So my English is not good enough, not good. So maybe this women's English is much better. So this is a NHK World News. So this is a news of the RFA.
Early stage breast cancer in Japan. They can now get a minimally invasive treatment covered by public health insurance. Tokyo Medical Center started providing the therapy known as Radiofrequency Ablation on Thursday under the insurance program. Doctors insert needle-like electrodes that generate heat and kill cancerous cells. Public health insurance schemes began paying for this treatment for early-stage breast cancer last month. At present, removing all or part of breast tissue is the standard treatment, even for patients in the early stages of the disease. Radiofrequency ablation is less invasive and poses less physical burden on patients. Researchers say a clinical study has shown it's just as effective as the standard treatment. Patients who have one malignant tumor less than 1.5 centimeters in diameter can receive the treatment at medical institutions certified by the Japan Breast Cancer Society. Kinoshita Takayuki, the doctor who led the clinical study, stressed the benefits of the treatment.
Radiofrequency ablation has the merit of not requiring cutting, but also offering accuracy. It allows patients to receive treatment while watching ultrasound tests in real time.
Kinoshita says the therapy can make use of diagnostic imaging, which is covered by public insurance in Japan.
It is important to properly diagnose the size and spread of the tumor through mammography, ultrasonic testing, or MRI, or to see how much cancer remains. Using these diagnostics is required for this method.
He said the method will reduce the psychological barrier stopping people from getting checkups.
In the future, if the number of examinations increases, the detected number of early-stage breast cancer patients will keep on increasing. The treatment itself will also be simplified. I think it will be a simpler option for both patients and doctors. For patients as a whole, treatment results will improve.
He says he and other researchers involved will work to make the treatment more widely available.
So my presentation is over. So thank you for your attention.
Okay, thank you very much. The wonderful talk and also wonderful video. We got the multiple questions. The number one is what is the maximum diameter of the region for radiofrequency ablation? I think the indication criteria question.
In Japan, the longest diameter is 1.5 centimeter diagnosed by every, including enhanced MRI and ultrasonography and mammography and palpation.
So how we can determine the size? I think the ultrasound is good enough, or MRI is mandatory if possible.
Enhanced MRI is very important because the MRI is very sensitive. So to the size and especially for the extensive intraductal component.
So if we understand the likeliness of the intraductal, the extension, what's your idea? How we can apply the RFA to the somehow the extended introductory?
So far, we exclude that kinds of cases. So if the MRI or ultrasonography reveals reveals suspicious of extensive intraductal component, in some cases we performed the additional VAB, vacuum assisted biopsy. If it shows benign lesions, we included the study.
Okay. In the file study, if my understanding is correct, the DCIS was allowed to recruit.
Yes.
And the question is, what is your opinion in RFA treating the DCIS?
So we exclude the DCIS cases with extensive calcification in mammography, of course. And of course, we exclude the invasive lobular carcinoma. So in some cases, we know some localized intraductal carcinoma. So in such a case, we included the study. So in that case, the enhanced MRI is very important to check the extent of the disease. Yeah.
So in your institution, who make a decision? It's possible, it's not. The
breast cancer conference before the operation.
Okay.
So the medical oncologist and the radiation oncologist attend the meeting. So.
All right, so great. And do you have any contraindication for RFA? It's other side of question. For instance, triple negative or HER2 positive unavailable?
If the tumor is depends on the institution. If, for example, if the 1 centimeter triple negative tumor, they give neoadjuvant chemotherapy. We exclude in such a cases.
So you don't know?
No.
Sorry, please.
I'm sorry. In our study, if the triple negative tumor size was less than 1 centimeter, we talk about the study to the patient. And if the patient said yes, we include the patient to the study. I'm sorry.
No, okay. Any concerns about toxicity or side effect of this technology?
Just skin
burns.
Only one cases.
Only one.
In our study, very low. And in some cases, we don't know why. Some cases, she feel some lump, soft lump over the study period.
Is there any particular procedure needed to prevent the skin burn?
Skin burn.
How you can prevent, or no need for prevention?
No, we put enough 5% glucose,
Glucose.
skin side and the muscle side.
Okay.
And we put the ice pack,
Mm-hmm.
the ablation site.
So that we need to learn something, particularly for this technology. I think
Yes,
the Breast Cancer Society now controls the
yes,
education program in Japan. Is that right?
yes. We have a video e-learning.
In video e-learning, that's great. And how the patient level or and also the psychological acceptance of RFA vs the excision surgery, open surgery, how the patient acceptance, or is there any particular concerns or worry in patients?
Oh, I don't know. I know in Japan, I know that lot of some patients we want to avoid surgery
Mm,
and move it to another hospital.
mm,
They are finding some chance to avoid surgery. So most of the patients, they don't feel any lump.
mm,
The tumor is very small. So they wish to avoid the excision and also small wound.
mm.
So I think most of the Japanese women accept the RFA treatment.
Okay. I think in the history of RFA in Japan, so more than 10 years ago, we got the slightly higher local recurrence rate.
Yes,
So because the indication was, the maybe 2.5 centimeter was allowed at that time. But so they got some recurrence, but according to your Raphael study, it's extremely low. So the local control is almost 100%.
yes.
So just simply this is because of the difference in criteria, or some more additional things, the improvement in technology, procedures, etc.
So the problem is we don't know how they treated at that time.
Mm,
And we don't know the indications and how many patients were treated by the RFA. We
mm,
sometimes find the patient recurred after relapsed after RFA.
mm.
So
Okay.
in that case, sometimes locally advanced, they gave the RFA to the locally advanced breast cancer cases.
Mm,
And in some cases, invasive lobular cases.
okay.
And in some cases, after after chemotherapy
Mhm.
case.
Okay.
So
So if we were careful enough, we can prevent the local failure in
I
most of cases.
yeah.
Okay, that would be good information for patients. Another very important question: how is the cosmetic outcomes compared with open surgery?
I believe, I treated a lot of patients over 10 years. So some patients over 14 years, 15 years passed after RFA. So
Mm,
they are still good cosmesis.
okay.
But some patients has not good enough. So we have pictures and questionnaire data,
Mm-hmm.
the Raphael study.
It's an American one or United States?
Raphael study.
Oh,
In the
I mean,
Raphael study,
the questionnaire was made in United States or the made by yourself?
questionnaire was made by EU.
EU. Okay.
So maybe soon we'll present the QOL data and cosmetic data.
So in your impression, the cosmetic outcome seems to be even better for non-surgical ablation. Is that right?
Yes.
Okay, so great. And another question, you commented already, but I would like to ask again, what about the TNBC HER2 positive cases? And have you got any experience the cases treated by neoadjuvant treatment?
Oh, thank you. We don't exclude the triple negative and HER2 positive cases. But usually, my experience, triple negative breast cancer, size of triple negative breast cancer and HER2 positive breast cancer is maybe bigger than that type. It's difficult to found in the small size. They are difficult to be found in the small size. But if a small breast cancer with triple negative or HER2 positive, if if the size was small and solitary lesion, we talk about the RFA to the patient. After RFA, we give chemotherapy and targeting therapy. It is same as breast conserving surgery.
Okay. So maybe possible in the absence of the neoadjuvant treatment.
So I will give the choice of the RFA or resection or chemotherapy. Okay,
sounds great. And this is another frequent question that how do you think about other non-surgical ablation technologies, like cryo or the microwave?
I don't. 10 years ago, microwave was active, but I don't know now what did happen to the microwave. But the cryotherapy, the big study was reported. Result of I3 trial was reported in the US. So maybe FDA, they will get FDA approval. So next cryoablation will come to our.
Okay. Another very important question, and now very small tumor postmenopausal, we tend to avoid even sentinel node biopsy, omit sentinel node biopsy. So what's the approach of the actual node assessment and sentinel node biopsy?
In our study, most of the cases, 350 out of 353 cases performed sentinel lymph node biopsy. But after reimbursement, we don't force to perform the sentinel lymph node biopsy.
Really? Oh, that's very good. Okay. The another question: can you explain the techniques that can prevent seeding when the inserting and withdrawing the electrode?
We don't. Some liver. Some IVR doctors of the liver talk about this seeding. I don't have any experience of about seeding of the cancer cells, maybe. So because we gave the patient to radiation therapy, adjuvant radiation therapy, so I don't think it's a big problem. It's same as vacuum assisted biopsy and core needle biopsy. We don't we don't care about the seeding of the tumors.
Okay, so you don't care at all.
No.
And hello from Indonesia. What would you do if we found no significant changes with the tumor nodule after RFA? Most of cases responded well, or
Yeah.
no resistance cases to the no.
Cases.
Okay, so no need for repeated ablation.
If the temperature, ablation temperature is not high enough, we try again.
Could you tell me again the appropriate the condition for RFA? You said in your lecture about the
Usually, targeting temperature is 60 degrees.
60 degrees.
Yeah.
Okay.
Less than 60 degrees, and we'll give the.
How long?
Yeah. How long? How long is it? Usually, ablation time is 5 to 10 minutes.
Okay.
One session.
Okay. So that would ablate most of all tumors, or maybe all tumors you can.
Yes.
Another important question I'd like to confirm or ask in RFA technology, the available pathological sample only core needle. So that means core needle biopsy seems to be very important.
Yes.
So is there any suggestion, recommendation in terms of the core needle biopsy considering the RFA?
Usually, after the reimbursement, we tested, in some cases, we as oncotype DX test.
Okay.
So for that examination, we need enough samples. So in RFA cases, we get more spaces before treatment by core needle biopsy.
Okay. I think we got the very excellent lecture by the Professor Kinoshita, and he kindly responded to all questions, and it's a very, very fruitful and very informative, and that was helped to expand this new technology, the non-surgical ablation with RFA, not only Eastern Asia, but also globally, I guess, and I expect. Thank you so much. Thank you very much.
Thank you very much.
Okay.